1. Go ahead.
All right, hello out there. We're starting our journal club for April 4th, 2018. Dr. Merlin is on his way. We're going to start off with some interesting cases. I just like to mention, May 22nd, Tuesday of EMS week this year, we're having our conference, Come One, Come All. We're actually going to be having a ceremony as well. We'll be honoring some people. You can see us on our Facebook Live. You can see us on Facebook, and you can also see us on our website at emsfellowship.com. All right. Anyone have interesting cases they'd like to go over?
I guess I can go over one that I had. I thought was pretty interesting. It was a 43-year-old guy who came in by BLS. I don't know if ALS didn't get dispatched or if they were canceled. I suspect they might have been canceled. And he basically was complaining of 1 week of shortness of breath. BLS said, that's all there is to the story. His vital signs are normal, his pulse ox is at 99% on room air, and that was the entire sign out. So we went to go talk to him. It was actually a prior team who was kind of toward the end of the shift. They started the case up. They went to talk to him, and really he said, I just had shortness of breath for about a week. It's been getting progressively worse. It seems to be a little bit worse when I'm kind of walking around or doing activity, but otherwise there wasn't really much to say. Oh, he had kind of an intermittent cough every once in a while. Might have had chills once, but didn't have a fever. Didn't have a fever on our vital signs either. The prior team was just leaving, and it was kind of change of shift. So I think when he came in, he was heart rate was 114, a little tachycardic, but everything else was totally normal. And they thought, well, let's get the blood work going. He had shortness of breath. He's a young guy. It's been going long. He had a bit of a cough. I think one of the first-year residents decided they were going to get a PE study. I'm not exactly sure why, because it didn't have many of the risk factors except for the tachycardia. The blood work was running. I think the CT had already been done by the time we evaluated him. And when we evaluated him, he was no longer tachycardic. His heart rate was like in the 90s, 90 to 95. He was truly satting, 98% on room air. It seemed comfortable, although a little bit tachypnic. Once you ask him kind of long sentences, he kind of almost had to break up the sentences. His lungs were pretty clear, a little bit of light rails. That was really it. No chest pain, no other symptoms, no other medical history, although we never really saw a doctor, so he wouldn't know if he had any medical history. And that was kind of it. And about that time, we get a phone call from the radiologist, and he basically said, well, there's no PE, so that's the good thing. However, I think you guys should add on a angiogram to look at the aorta, because it appears that there might be a dissection of the aorta. So added on an angiogram, got thin sliced CT, and turns out that this guy not only had a dissection, he had a dissection, which is actually where the inside of the aorta tears away from the outside of the aorta, and blood gets kind of in the wrong place. And that started actually right by the aortic valve, dissected into the valve, and actually had torn open the valve, and also extended all the way into his both coronaries, and then extended all the way down toward his kidneys, but didn't make it quite to his kidneys, but it was well on its way. Ended up getting rushed to major heart surgery and had total reconstructive heart surgery. They took out the top of his aorta, put in a cow's aorta, and then they reconnected the coronary arteries to the cow's aorta, and they also put in 2 mechanical valves for him. So actually had a pretty significant surgical operation for really what sounded kind of like a benign complaint, and that everyone was almost putting aside. But for somebody, I think, almost accidentally ordering a PE study, this person easily might have been, go home, see your cardiologist, or hey, you're not that sick, you can easily be released to BLS, except for the tachycardia. Right, so I thought it was interesting that that's how it played out. Typically these aortic dissections have pain. Classically, they're tearing, severe pain. Nothing makes them comfortable. His EKG was totally normal. He had no signs of STEMI on the EKG, even though he had dissected into his coronaries. Maybe that happened after we did the EKG. Often, or sometimes you can see a STEMI pattern, so that's one of the things we always have to think about. If we see a STEMI, right, the occlusion may be a ruptured plaque, or it may be a ruptured vessel that's causing the decreased blood flow. But I was really, really surprised to see that. I think everyone else was too, because that's not what we were expecting, especially with such a benign sounding story and almost normal vitals except for the tachycardia. That's why when I always get these calls for a release to BLS, and they're like, yeah, it's a 103-year-old person, they feel well, they have this generic complaint, their vitals are normal, oh, and the heart rate's 130, and I was like, wait, because right, that's just so hard. These abnormal vital signs, they can be that can be the only clue that we can latch onto to really get it figured out. And you know, if that might be their moment to decompensate, and you don't want to be the last person to touch them, especially when we can intervene and help them and fix them.
There's a saying for that. It's called a hot potato.
Yes.
Yeah.
Yeah, one of the big things that I always talk about is the classic presentations are usually like 30% of the time. Although that's what we learn is the classic presentations. The classic presentation in my mind is for an aortic dissection is someone who is diaphoretic, hypotensive, they just look sick. But I found multiple times where that's not the case. And I think I worked with one of the medical examiners, and they see a lot of aortic dissections come to them when they do their autopsies, because they get an unexplained death, young person, they do an autopsy and they find aortic dissection as the reason a lot of the time.
Yeah.
I had a similar case. It was actually sent home from another hospital with flu-like symptoms, and something just triggered it. The patient came in just not feeling well, weakness. They had the specific story that 3 days before I saw them, they were eating ice, and they swallowed the ice, and they said it felt like a tearing going down their throat as the ice went down. So if you've ever had bad pharyngitis, you had a bad sore throat or something, you can understand why they would feel like that. But in this case, I did an EKG because the patient was in her 60s, upper 60s. She was like, oh, it's tearing down. She had chest pain. So I'm like, okay, flu-like symptoms. Let me get a chest X-ray. It was during flu season as well. I didn't send a flu swab because, if it's not within 48 hours, what's the point? And she had a STEMI on the EKG. And I remember distinctly, I called the cardiologist, a very good cardiologist, and she's like, oh, could this be a dissection? I'm like, it's not a dissection. And so I did a PE study because she was also hypoxic, which could also go with the flu-like symptoms in an elderly person, pneumonia. Her chest X-ray was a little bit, it wasn't any consolidations, but there was congestion because her heart was dying. But and it turned out during her PE study, they said there's no PE, but she has a very large dissection that went back to the valve, and that's why I saw the STEMI on the EKG. It actually went up her carotids and then all the way down. So it was rather extensive. And I couldn't blame the other hospital, because if she came to me and I didn't have any EKG findings, I would have probably just sent her home with flu-like symptoms, maybe a bronchitis or, brewing pneumonia, give her something, antibiotics, steroids, something along those lines. And that's why you have to keep a very wide differential. Anybody else with aortic dissection cases?
There's one question about Drew's case. Did he look like Marfanoid?
So he actually was a kind of a tall guy. He was African American in race. He was kind of tall. Did he look Marfanoid? Not exactly, but I actually did consider that too. I thought of that exact same thing.
Yeah.
I don't know. He certainly didn't know, and I don't think anyone has actually done any other genetic testing to find out.
Yeah.
But I did notice that he was a little tall and skinny.
So the reason why they asked that's one of the risk factors. Some of the Marfanoids, they basically don't have the same collagen. So tall, lanky people are more at risk. People with hypertension because of the tearing forces.
Mm-hmm. Shearing.
One of the things that you want to look at for dissection especially is, like David said, was 30% of your classic presentations. But the reason why is because dissection can involve so many different kind of pathways. To your STEMI being, dissecting into a coronary. You can dissect into the pericardial sac and have a hemopericardium. But now you're having tamponade physiology. So, having a STEMI presentation for dissection versus like a cardiac tamponade for presentation versus, neurological symptoms because you're dissecting into the carotids and having neuro findings, so looking like a stroke. And then when you get like your type B dissections, you're talking about, dissecting now downward into your renals, you're talking about dissecting into your iliacs, and so people come in, a couple years ago, one of our other attendings talked about a case that he had, the presentation was basically hip pain. And this patient was dissecting through one of her, iliacs. I mean, and it's very common to see these very unique presentations, and a lot of it comes down to your physical exam. Do you have unequal pulses? Do you have a faint pulse in one leg? So people who come in with right lower extremity pain or like numbness or tingling, and you got like a faint pulse in one leg, think of dissection always. So these are the hallmarks that you think of, but it's not the classic presentation that you get, but at the end of the day, this is what dissection is. It's all over the place, and it involves the major vessel, which can then kind of cascade into other parts of the body. So having a keen eye, and like I always say, if you don't keep it in your differential, you'll never think about it, and you'll always miss it. But if you always keep it in your differential, at least you're kind of brushing over and saying, could this possibly be it?
That's
Yeah,
true.
what he
Back
was-
when I was a resident, he always said that about patient came in with ankle sprain. He said, keep dissection in your differential.
Right.
When I was telling one of the other residents about this case, they mentioned one that they had not too long ago of a guy in the urgent care setting, and they basically, their complaint was like, my foot is numb, my right foot was numb and tingly, and for some reason, I guess they thought to check pulses, and he actually didn't have a pulse, and they're like, that's weird. Got a Doppler, didn't have a Doppler pulse, and then they started doing some more investigating and ended up getting a CT, and he ended up having dissection down to his iliacs.
Yeah,
Right?
when you
And
have,
it's so easy to brush off. It's so easy to brush off.
yeah, keeping a wide differential, especially like even if someone who has chest pain and the hip pain, like you were talking about, like what connects the hip and the chest? The aorta.
Right.
And when it's tearing open, it's
Quote of the century.
Aorta.
like what connects the two? It's the
So-
very large vessel.
Interestingly, this wasn't one of my interesting cases, but I did recently have a dissection patient, and she had a known type B dissection. She came in, she was like a 68-year-old, and essentially she was dissecting, her dissection flap was dissecting. So the flap, the intima flap that
Wow.
was going through had started dissecting. So comparing the previous scan to the new scan, you could see the dissection flap has started separating. So she had 3 lumens. And I think
That's
we should
crazy.
look that up, because I've never
That's
seen that
bizarre.
before. Vascular surgery was like, oh, that happens all the time. It's like, right. I don't know if I've ever heard of that ever happening. So.
Yeah.
And what the guys were talking about, the type A, type B, that's the Stanford classification. And A is for ascending, that's how I remember it, and B is descending. And that has to do with therapy. So one is medical, one is surgical. A lot of times they'll do endovascular, where they'll go in and put in sheaths. But for the pre-hospital providers, the thing is just keeping your differentials wide. So in my case, it was a flu-like symptoms. And like, I barely thought about it, but I kept my differential wide, I did the EKG, I did the other things, and that helped. So,
Yeah. It's definitely an interesting case.
yeah. Any other comments about the aortic dissection? All
So
right.
I guess my case.
Yeah.
Or did you have anything?
Please go ahead. I'll go.
So your guy was tall and skinny. Mine was short and not skinny. Gentleman in his 60s, probably mid 60s, coming in. Diaphoretic, severe, just distress. Paramedics found him with a heart rate in the 30s. Blood pressure was 60/40 at that time. Initially, they were having difficulty palpating a pulse, but then they were able to find one, so they decided to start pacing him. So he got some ketamine, and they began pacing him. So he came in pacing. He was intermittently capturing. Blood pressure had come up a little bit to like 70s/40s. I think primarily because even with milliamps pretty high, he was just kind of intermittently capturing. So. What do you think the first thing I did was, once I saw the severely bradycardic rhythm and hypotensive patient? Okay, I gave calcium chloride, so which did nothing. So it was worth a try.
But that's the thing. The low side effects. If they were hyperkalemic. That's why you were given it, I'm assuming.
Yes, yes.
Weird. You would literally see a change from this bradycardic wide complex, maybe a sine wave even, turn back into normal.
So this guy, I actually, I turned off the pacer while I did my ultrasound to kind of see where he was and repeat a blood pressure. And his heart rate dropped back down to the 30s, and it wasn't a complete heart block. It was a very slow, what I would call a junctional rhythm. It was regular, and it looked just like a very, junctional rhythm, which is strange. I've never had one of those that I've had to pace because they were hypotensive. But still, we turned it back on, gave him some fentanyl, started pacing him, and his blood pressure came up. But he's still, even with the milliamps cranked up, you're kind of playing with pain versus pace, and we didn't want to make him too uncomfortable, so you try to sedate him, but you don't want to sedate him too much because then the blood pressure might start to creep down. So long story short, we ended up pacing him, and I threw in a TVP, so just because he was kind of intermittently capturing transcutaneously.
So TVP is
transvenous pacemaker. It's basically a large catheter cordis that goes into the neck here. It's called a cordis, and most kits are going to be anywhere from 5 to 7 French, so pretty big. And you're able to pass a wire through that, goes down to, it's supposed to go into the heart, and ideally down into the right ventricle where you can start pacing the ventricles. The placement is sometimes an issue, especially on this patient. He had a tricuspid regurg, which means a backflow from that initial valve that you see as soon as you get into the heart. So the wire, as it's starting to pass into the heart, whoosh, would go out and flop over, the wire would flop back over into the IVC. So that was interesting. That happened to me once before. So I was able to pull the wire out, kind of curl it a little bit, and then get it to ultimately go in. I started pacing him, and ultimately he ended up doing okay, but in terms of causes, what came back, CBC came back, there's no white count or anything, chemistry came back pristine. So I'm like, what the heck is causing this? TSH came back 120.
Huh.
So
the
this guy
thyroid
had,
stimulating hormone was very high, meaning that there was low T4, T3.
right.
So
he was
maybe
like myxedema coma, altered mental status. He was severely bradycardic. I gave him 1 dose of levothyroxine,
which is
turned off the
artificial
pacer.
thyroid hormone. Yep.
And that was it. And within 30 minutes, he was improving. I've never seen anything like that in my life. So it was pretty cool. But now he had a TVP, and
Yeah, I mean, interestingly enough, what made you order a TSH?
I don't know. That's kind of on my differential for weird bradycardic rhythms, altered mental status. I'll throw on a TSH, and weird tachycardic dysrhythmias. I'll throw on a TSH. That kind of stuff.
I've had a couple of those, and it's kind of like this part of my super sick patient bundle. When they're super sick, they get a TSH. Whether super sick turned up all the way or turned down all the way.
Yeah.
Right. These acutely psychotic people can be sometimes thyroid problems.
Now, pretty much at every hospital. Whoa, Siri thinks we're talking to her. Every hospital I've been at, TSH is readily available, and it's a quick turnaround. Thyroid hormones otherwise, like free T4, sometimes that should be available at most hospitals, but sometimes it's send out. But TSH is one thing that you can pretty much get rapid turnaround on.
Yeah, it's a screening exam that we do.
Yeah.
And other things that the thyroid can really cause is the altered mental status. You can think about thyroid storm as well. So reasons for altered mental status, palpitations, different cardiac arrhythmias. With your case presentation, so they were severely bradycardic. So if you have a patient who comes in who is bradycardic, diphoretic, maybe a little bit altered, are you going to wait to draw up the fentanyl, the Versed, the ketamine, or are you just going to start pacing them? Because you know, just like me, that someone's going to be like, oh, you can't pace them until you sedate them or give them pain medication.
They're altered. They won't remember.
Yeah,
it.
if they're altered, so I kind of did a trial before giving this guy fentanyl and turned up the milliamps. And once he started saying ow, 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 it's like, okay, it's like a TENS unit. And then he said, no, it's not. So it's like, okay, he's feeling pain. So
So you pulled back a
we
little.
pulled
bit.
back a little bit on the milliamps.
I
but
mean,
then he
I
was captured,
personally I
so-
feel like perfusion to the brain is important.
Yes.
Mm-hmm.
So if they're diaphoretic altered, I will start pacing and just get the medication faster.
Yeah.
I'm not going to wait for the medication to treat the unstable patient.
Right.
I mean, one of the biggest things that you want to think about is also, I always talk about bradycardia, and I always say, well, is their ultramental status due to their bradycardia? And it always comes down to the blood pressure. If you're perfusing, I mean, if you have a good maps, you're sustaining good maps, you're going to perfuse. So, I mean, you have to start thinking, okay, what is another reason for someone's ultramental state? So, I'm not always quick to just start pacing someone, although, their blood pressure may be stable. So, it's a kind of a mixed picture. Now, that being said, scenarios where you're having to pace patients, Bob, you might be able to kind of give us some feedback on this. How many times have you seen that being unsuccessful? Around the first time, and they had to dial it up and increase the milliamps, and I mean even increase the joules, and even the rate sometimes to see if they can get capture. And what are some of the tips that we can provide our EMS providers, and maybe maybe switching the pad vectors, or maybe how quickly you would escalate your joules or your rate?
Yeah, many times, we won't be able to get much capture at all.
Mhm.
I mean, we're always told to start, at 70 and 70, and, hardly ever get capture at 70 milliamps.
Right.
And, we're getting up more towards the 100 milliamp range before you start to get anything. And I really think, and it's anecdotal, but I really think that very few times we get full capture
Right.
doing transcutaneous.
Mhm.
Yeah. And I mean, I've seen that. I've struggled with that as well. From time to time, I've had it where I'm not able to get capture, and so then I sit to think to myself, what's the next best thing, and what can I do next? And sometimes changing your vector, maybe doing anterior posterior instead of the anterior lateral, and then definitely going up on your milliamps, and then kind of increasing the joules, so that way you can better optimize your capture. But these are things that we can always do. Sometimes troubleshooting is half the battle, especially with pacing. It's not just a quick hit of a button and it's presto, you got it going on. And the other thing that we always see is sometimes patients, or even our providers, can sometimes, think they're feeling a pulse, but what they're really feeling is this jerking of the body when actually you're not even capturing. And that's also something that we commonly see as well. So, there's a lot of troubleshooting that goes on with pacing, and a lot of times we do see sometimes these fallacies in how we pace patients. Obviously in the pre-hospital setting, we're hoping to get, pre-hospital ultrasound, to our medics and with us there. But, in the hospital, in the ED, what we're doing, more and more routinely is echoing the heart while we're pacing to see if we actually see contractility, and are we pacing and are we capturing? And that's huge. That's half the battle, is actually being able to visualize the heart and say, okay, yes, we're captured, and yes, we're pacing. And that's really the definitive way. And this is kind of why we want to be able to bring, pre-hospital ultrasound, point of care ultrasound into, the pre-hospital arena, so that, there's more definitive management and definitive care by our ALS providers.
That's a great pearl that you taught me in residency, by looking at the heart while you're pacing, because we were having pretty consistent electrical capture with this guy, but looking at the heart, there was not
Right.
mechanical capture.
Right.
So
Very deceiving.
so
Very
yeah,
deceiving.
so and you could see, once we got the wire down in the heart, you could see the wire there, and you could see the heart contracting with every pace that the TVP was doing. So that's really a big pearl. Yeah.
So, some of the good things for whenever I pace someone, I actually prefer the anterior posterior position. Also trying to avoid any chest hair, male or female, or implants.
Yeah, I think it's a function of body tissue as well.
Yeah,
so.
you want to reduce the amount of distance between the two pads, and you also want to think that you want the heart in between the two pads.
Yeah.
I keep a razor inside my actual life pack so that we can just quickly shave the area. Some people will have extra pads and they'll just put one pad on and just do a quick, waxing of the area. But those pads are expensive, and the reason why you carry two is not for that. You carry two because, you may need the other one. And then the other tidbit is to make sure that your rate is far enough from the intrinsic rate. So if you're 30, it's not such a problem. But if you're, 40, 50, but you're not perfusing, then you shouldn't set it to 60. You should be shooting for 80,
Yeah.
something along those lines. Dr. Merlin's here. I'll give you this microphone.
Welcome, Dr. Merlin.
Thank you.
We're just finishing up our talk about pacing.
Yeah,
We had a
good,
bradycardic patient who turned out to be myxedema coma.
Yeah.
And
Yeah.
then prior to that, we were talking about aortic dissection. Uncommon presentation because we've had several cases of that.
Pacing transvenous or transcutaneous?
Well, we
Both.
Because transcutaneous pacing doesn't work as well as everybody thinks it does. It
Right.
just doesn't capture. Sometimes it's certainly not a be-all that we all think it is.
I have the best success transcutaneous pacing with the, I mean, I hate to say it, but the frail little old ladies where there's not much tissue in between, the pads. So,
but that's why the
Um,
transvenous works better because we are literally inside the heart.
yes, yeah. There's one article they always talked about in CCU, which was if you're trying to affect ventricular muscle tissue, the anterior lateral pad positioning is usually the best for most people.
Okay.
If you're trying to affect the atria, then anterior posterior is going to be better. So like for a synchronized cardioversion and like an unstable AFib RVR or something like that, anterior posterior has been shown to be better. So
We talked about the benefit of calcium chloride for bradycardic rhythms.
we did. I
That's the first
gave
thing you
calcium
gave?
chloride. It's the first thing I gave. This guy was in the door. Didn't touch him. So
What, was it potassium normal?
potassium was normal.
Yeah.
Yep. So it was an interesting case. And looking back after the TSH came back, it's like, oh, duh, this guy looked like a myxedema. Like he looked like a hypothyroid, kind of guy. So
Well, what was the TSH?
it was 120.
Yeah, 120 is impressive.
Yeah.
You don't see
I didn't think it
120
went that
every
high.
day. Yeah. You don't see 120 every day.
Yeah.
And you gave a synthroid and within
I gave
How
levothyroxine, and they called down from the unit and said, oh, we're not even pacing him anymore. So he pretty quick.
But you have to think if the TSH was 120, didn't that patient have like severe symptoms? I mean, how'd that patient get out of bed in the morning?
So the bad part of that is he was just discharged from the hospital
Really?
less than 2 weeks ago. So
For generalized weakness.
just for general,
For
yeah, it was
generalized
like a
weakness?
really not. It was like a very vague complaint. So
And they didn't get a
abdominal pain or
TSH?
something like that. So
Did he get a TSH?
not that I saw.
So generalized, I don't always send a TSH for my generalized weakness, but if there's generalized weakness to the point where they're being admitted to
Yeah.
the hospital,
yeah,
I would
it's
send
part
a
of the
TSH.
workup.
I mean, I think the high, I know actually somebody who was a physician who had a TSH of 88, and I remember. And her endocrinologist said to her, how'd you get out of bed in the morning? And
Yeah.
she goes, I just felt really, really tired. And the 120, that guy must have been pretty symptomatic for the last couple of days.
He came in looking terrible. He said he's unable to stand up by himself. He was severely diaphoretic. He was unresponsive by the time the paramedics got to him, so they started pacing him pre-hospitally. So
And the thing is, but a synthroid dose usually takes 4 to 6 weeks to change, right?
Oh, really?
So,
So maybe my dose isn't what changed it, but
IV?
I gave him yeah.
Oh, so we're talking about PO. So,
Yeah, IV.
so
IV is gonna
that's
be
why when you
different.
change TSH, you typically, like an outpatient office practice, you typically would check the TSH maybe, in 4 to 6 weeks to
Yeah.
see what kind of implications it has, because there's so many synthroid pills now, such small doses.
Yeah. So
All right, do you have anything else, any interesting cases? We're gonna switch over to some of the journal articles, and we actually have our statistician on the line. We're
Yeah.
trialing out some remote viewing, so we will bear with us when we get to that part. But we have a specialist in statistics who can actually help us understand some of the things that we're going through.
So I'll introduce you on the camera. So AJ, you can say hi to everybody. I don't know if you can hear us by now, but so I've got. So that's AJ, and AJ is going to be commenting on some of our articles. He's been helping us a lot with statistics over the last few weeks, so it's a pleasure to finally meet you in person. We feel like you're here because this webcamming is so great, but we will get into the articles and we'll get you back on there. So
Whatever article you guys want to do first.
all right, so we had some good ones. Let's see. I mean, I have to talk about TXA. So, I mean, I'm happy to start with TXA.
You just want to do the review? All right.
The review. We can start with just a quick review in postpartum hemorrhage and TXA. This here actually. Let me put up the image so everybody can follow along with what we're doing here. But I thought this was a good kind of perspective review, just in that you can really see, bleeding, and especially peripartum or postpartum hemorrhage internationally is a huge problem. This was kind of an eye-opener for me. I mean, I know it's bad, but once you start seeing the numbers and everything like that, you really see how many people are affected by this. And such a cheap and readily available medication. I mean, there's a reason that the World Health Organization included TXA on their must-have list, essential medications or essential medicines list. So this was just a great review. I'll just kind of summarize it really quick. This was looking primarily at postpartum hemorrhage. As we know, it affects low-income countries, and TXA, which we've discussed probably on a weekly, at least multi-weekly basis here. We know that has been shown to reduce death due to bleeding and trauma. And we did review the woman trial, which demonstrated a significant reduction of bleeding in bleeding-related deaths in patients who are postpartum hemorrhage. So the risk ratio was 0.81. So long story short, they kind of get into the global issues of maternal bleeding deaths in this review. There were goals back in the 5th millennium, quote unquote. The 5th millennium development goal was to reduce maternal deaths by 3/4 from 91 all the way up to 2015. Essentially, nobody's achieved this. They quoted a number of articles that show there's just, especially in developing countries, there's no change. People are still dying. A lot of people are still dying. For example, Sierra Leone death rate is pretty much the highest in the world. There's one maternal death for every 74 births. That's enormous. If you think about 74 births, when I was on my OB rotation, we saw that in probably a couple days when it's a full moon. So if one person was dying for that, I think about that. That's just that's not really tolerable. That's terrible. So in the UK, even in the late 19th century, there was 108 maternal deaths occurred for every 100,000 births. Developing countries like the UK has dropped. Now they're 0.56 per 100,000 births. That's a huge drop, but still we're not seeing in developing countries. So that's kind of the beginning of this article, just an impact factor. It just kind of gives you the background. So they kind of looked into why. Why is this happening? Africa has a lot of issues on its own in terms of medical health. For example, anemia in Africa is a major syndrome due to multiple etiologies. Iron deficiency is a big problem, primarily related to infections like chronic disease, iron deficiency related to that. So HIV is a big problem. Sickle cell, thalassemia, glucose 6-phosphate dehydrogenase deficiency, parasite infections. That's one thing you don't think about, but parasite infections can be shown to induce blood loss over time. Hookworm infections, things like that. Just need some albendazole, right?
We'll put it on trucks?
Yeah, I think that's something we should start including. So anemia is a huge problem, and with that underlying population, postpartum hemorrhage therefore is going to be more lethal. And also, many countries, especially in Africa, they just have no facilities to prepare or house or maintain blood products. That's a big problem. I know we've talked about some kind of freeze-dried blood products. So in the last few journal clubs, that's somewhat promising, easy to reconstitute. They have a really long shelf life, and they've gotten better since World War II. But it hasn't quite reached that direction yet. And also, what they're saying is you really just need packed red blood cells or whole blood in these patients. You just have to transfuse the heck out of them in order to make a difference. And what do they have? So if they don't have blood products, they have synthetic colloids and crystalloids and things like that. So people are getting bolused a lot of fluid, and that's not, as we know, that's not what we want to do in major hemorrhage. So.
And it gets missed a lot because if you remember, with thalassemia, the MCV is out of proportion to the degree of anemia, right? So it starts at a subtle anemia with a very low MCV. So that's like a tip-off.
Have you ever heard of hetastarch?
Yeah.
My wife uses that all the time in animals. I've never used it once or seen it in a hospital. Is it still around?
Yeah, it's still. I mean, it's still around. There are places around the world that are doing it. You know, it's. I mean, the outcome studies in humans has not been fantastic,
Yeah.
and we're all very hopeful that the next drug they'll all be giving is FDP, freeze-dried plasma.
Yeah.
When we give FFP with blood and platelets and cryo in trauma centers, our challenge is that we don't have very good temperature control in the pre-hospital setting.
Right.
And FFP stays thawed for about 5 days if you don't use it, but freeze-dried plasma you don't need to keep cold. So once it's available to the masses, it'll be a really perfect drug. We have the ability to give blood products in the pre-hospital setting for us for the last couple of years. But you know, blood has to stay between 2 and 8 degrees Celsius. It's just, and it has all these requirements. How often you have to check temperatures, et cetera, et cetera. So it's not ideal in the pre-hospital setting. It's challenging to routinely utilize it. Whole blood or walking blood banks, which is what the military does, is much better. You know, you get a call overhead that you need blood from like the recruits. But that's a different population in a closed environment because most of them have, you know, they've all been screened prior to.
They're healthy, they're young.
Yeah.
And it's
they've
also
been-
their buddies, so.
Right, so they've been screened, so it's much easier to have a walking blood bank in a military situation than in a civilian world. But yeah, getting back to Africa, the problem is the anemia can be very subtle with beta thal, one of the most common causes of anemia, until later on in the disease process.
Yeah. Yeah, and they also got in a lot to the pathophysiology changes in pregnancy, and they talked about, you know, overall there's a net increase in coagulation, but you also have an increase in the amount of endogenous TPA. And as we said before, what's a direct inhibitor or, you know, antidote to TPA? Well, TXA. Just try not to confuse them when you're deciding what to give to a patient. You know, that they talked a lot about that, and overall, essentially, again, it goes back to the poor pre-existing conditions in Africa where coagulation would be affected, and you just have overwhelming hyperfibrinolysis, which, as we discussed before, your body's making clots normally, and as it makes clots, there's a balance, so it has to start breaking clots down. And when there's major trauma or major hemorrhage to the endovascular system, or the vascular system in general, there's your body's going to start breaking down clots kind of erratically and just go crazy, essentially. So your ability to maintain and therefore form more clots afterwards goes away. We want to try to prevent that from happening. So let's see. And then just they talked a little bit about comparing different antifibrinolytics. So antifibrinolytic would be something that stops that breakdown of clots in your body. And, you know, apoprotein is a serine protease inhibitor. That's something that used to be used for years in cardiac surgery. And then the BART trial came out. I think we've talked about that, or we referenced it before. But the BART trial came out and just showed increased 30-day mortality in the aprotein, I said that wrong before, group, compared to lysine analog groups. Now, TXA is a lysine analog, and also, which we also see in like use in peds and sickle cell, is another lysine analog, aminocaproic acid. We don't see that too much anymore because TXA is better, you know.
But we see it in other countries.
Other countries, yeah.
Right, so you see people on the PO, you know, like for other countries, they give it routinely. So I've seen people who like are coming on planes and
Yeah.
then they're on a PO.
Aminocaproic acid, you mean?
Yeah.
Yeah. You know, this was back in the 60s where Utako Okamoto, it was a husband-wife team, they came up with TXA. It's just a much more concentrated form of a lysine analog. So TXA is available over the counter in other countries, in Japan included, for like, you know, heavy periods, and it's something that's readily available. They go more into there's some great diagrams in this article about normal fibrinolysis and then lysine analog inhibition, you know, showing just where that happens in the cascade. Overall, the woman trial especially was something that was really a big, large population, was like 20,000 patients, where they demonstrated a reduction due to bleeding. What do we worry about when giving TXA? Increased thromboembolic events, right? That's what everybody's scared about. They had 20,000 people where they demonstrated that's crap. It doesn't increase your thromboembolic events, right? We also saw that in CRASH. And it also doesn't affect breastfed babies. So all these mothers who were getting TXA in the women's trial were, breastfeeding, and the babies were not affected. They didn't develop DVTs. At least, I don't know if they were screening DVTs.
But it does cross the placenta.
Yep, it
right?
crosses the placenta, and it also is excreted in milk.
So for a woman who was having a spontaneous AB, though, it may not be the best choice, because if there's any viability to that fetus, TXA will end the fetus's life.
Yeah.
Potentially. So.
So pregnancy, not good.
I remember most women who are having heavy vaginal bleeding is more likely to be a spontaneous AB than it is ectopic, right? So ectopic causes less vaginal bleeding in all comers. I mean, here's a question. So what are the indications for it in postpartum hemorrhage for TXA? Because most EMS systems don't carry Pitocin pre-hospitally.
Mm-hmm.
I've never quite understood why, though. It never really made sense to me. Because if it was me, I would put it on ambulances. I don't know if
How often was it used? That's the question.
well, I mean, it's probably an inexpensive drug. If somebody is having postpartum hemorrhage, what's the downside? I mean, certainly PIT can cause hypotension. On the other hand, which we all know, on the other hand, it does help postpartum hemorrhage a lot. Down in a hospital, the emergency department, we give this to like everybody, right? Everybody gets PIT who's having postpartum hemorrhage, and we have a fair amount of deliveries in most emergency departments, right? So on a regular basis. So why? I don't know why we don't carry it on ambulances. And then when would be the indication to give TXA to a woman with postpartum hemorrhage?
So this study, one of its actual criticisms, which I don't think it's a criticism, is that the inclusion criteria was not well defined. Same thing with CRASH 2. They basically left it up to the discretion of the provider. If the provider thought maybe this patient might benefit from TXA, or no, they're not going to benefit from TXA, they were actually excluded. So anybody else kind of in the middle, in the gray zone, they got it. So if they were just having postpartum hemorrhage, and whether they're stable or unstable, they didn't really define that inclusion criteria. So
Right, because you probably don't need to be symptomatic, and you probably don't need to have abnormal vital signs, as we've proven in trauma.
right.
So it's just another drug that we don't know how to dose and we don't know the indications for, but we know it's really good.
Mm-hmm.
I don't know. I would put PIT on ambulances because I'm not sure I see the downside.
We have Sam Benson who said that they used to carry PIT in New York City for a few years, but they pulled it because lack of use.
I remember I had it when I was a medic.
Right.
But
Yeah,
no
me
one
too.
ever
I had
used
it. I had it as a medic, but I mean a lack of use. So I would say, how many outside deliveries happen in the city in a year? It has to be at least a couple.
Yeah.
A couple of those women are having severe postpartum hemorrhage. So why not have the ability to give it? I mean, the downside is you could make hypotension worse. I mean, you just have to know that. So you probably have to give it
And you
not
also
all
wanna,
that fast.
You also want to make sure that the placenta is delivered. But you collect what you can.
Right.
And then if they're hemorrhaging, it doesn't matter.
And I must say, for all the
Just give
times
it-
that people started PIT before the placenta was delivered,
It's okay.
Yeah.
Or, I mean, everybody learns in the textbooks not to pull the placenta out. But we all know in reality, we pull the placenta out every single day, all day long,
Yep. Just don't tear it.
and we get a rush of blood. I'm not telling people to do that, but in real life, this is what we do all the time. I mean, this is what OBs do for a living, one after the next, after the next, after the next, right?
It's just gentle traction, right? That's it.
Exactly.
Right. So,
And they're always giving Pitocin in very large liter boluses. They just mix
It's
it in,
wide
give
open.
it slowly. It's wide open.
It's wide
You
open.
can give it IM as well.
Yeah.
I mean, we give it, how do we give it? We give it like in lactate ringers, right? Wide open, but if there is persistent hypotension, you do give it a little bit slower, right? But are they bleeding? Are they hypotensive because they're bleeding a lot or because of the PIT? I guess if you just start the pit and the blood pressure drops, it's probably the pit.
Then another potential delivery they talked about is topical TXA. In theory, it's faster local bioavailability. You know, it's readily applied right directly to the site. But I guess, are you going to be doing uterine packing with soaked TXA? I mean,
I mean, in the hospital, we would just use a speculum, or no, I guess we just do it manually. And then, I mean, would you put it on McGill forceps with a 4x4 and soaked in TXA, and then just put it around the open cervix, or would you do it manually? What did they?
They talked about using an intrauterine balloon soaked.
Yeah, with
gauze
like
soaked
gauze.
catheter, basically. Intrauterine, let it sit for a while, take it out.
Intrauterine balloon,
Balloon
meaning like a
catheters.
Foley in an open cervix,
That's kind of what they were
Impregnated.
describing.
It just says impregnated with
Or like a
TXA.
They
Fogarty-
So
didn't
Fogarty
really mention it
catheter
except for
kind of thing?
mentioning the name.
I guess that makes sense too, because then you're delivering it more topically. Although, I mean, this is a non-visualized balloon. Although I guess you could use ultrasound, and if there's a lot of blood in the uterus, I mean, I guess your goal is to just.
I think the thought process was more for like emerging health systems where an
I
IV
see.
may be harder to get than just having some kind of pre-made balloon.
I see.
Less so in the U.S. where it's probably easier for us to get an IV and just give it IV.
Yeah.
Sim
Or-
Shane says that it's pretty rare for them to deliver the placenta in the field, and they do a lot of deliveries.
So it's pretty rare because because you're not with a patient long enough. But in the hospital, I would say in the emergency department, it's not that common for the placenta to be delivered either. We just pull it out, right? I mean, that's kind of the fact.
So it either comes out on its own, or if it's a pre-hospital delivery, that's the first thing we check for. Where's the placenta? And we want people to bring it in as well, so that we can actually see, like, is the whole placenta out?
So,
Right. There's two. What is it? Dirty Duncan, and what's the other side?
Dirty Dun- I've never heard of
I've
this
never
before.
heard.
You never heard of that?
No.
So one side's called Duncan, right? And that's kind of the rougher side of the placenta.
With all
So
the
people
veins.
nicknamed it Dirty Duncan,
Uh-huh.
right? And then the other, so what's the other side of the placenta called?
No idea.
I'm guessing the dirty side is the one that's actually connected to the.
Drew?
I have no idea.
You looking
I
it up?
just remember my job as a medical student was, go and inspect the placenta, make sure the whole thing is there. And I'm just like, how am I supposed to tell that the whole thing is here? Like this.
Right. All right.
So basically, they kind of wound up the article talking about TEG, thromboelastograms and thromboelastography, or however you'd say that, elastogram.
So we discuss this over. So what's the bottom line, Mike? Is this worthwhile? Because people are
No.
investing in this. They're using it in hospitals and trauma centers.
There's a huge Cochrane review that looked into this. They looked at all the studies. They did a great meta-analysis. At this point, they're not there. They're expensive systems. You have pretty quick turnaround on PT-INR and platelets. That's the standard of care right now. And to wait for the thromboelastogram printout and all that, if you identify hyperfibrinolysis at that point, it's too late. So.
Right. So it's not what your
it's just
platelet count
delaying
really
care.
is. It's how many platelets are really working. It's dialysis patients probably have dysfunctional platelets. I mean,
Yeah.
lots of diseases have dysfunctional platelets. Even though the lab says it's 300,000, it's probably maybe half of them are working.
Yeah.
Dirty Duncan and Shiny Schultz.
Yes,
There you go.
that's it.
Yeah.
Right. So that's the two sides of the placenta, Duncan and Schultz. And to just remember, because Duncan's kind of
Never heard of this in my
the
life.
rough side,
Right.
and Schultz is just the shiny, clean side. So you just want to make sure one is shiny and one is dirty.
Okay.
Were those actors, notorious actors?
I
or
hope
something
all
like
I can say is
that?
I hope that question's not like on the final exam for EMS
Yeah.
boards. Or,
I don't think it is.
okay, so that's your review. You want
yeah,
to just
that's
do the
pretty
next
much it.
article, or you want to do like one of the research? I mean, I don't include that many reviews. Or I try not to, but
Yeah.
I don't know. I thought this was a good review.
Do you want to give AJ? I don't know, AJ, if you have anything to comment on.
Well, there were no
that,
real
that,
stats, right?
That review, aren't really many stats or anything like that, but
There's not a lot of stats with this one. One thing I noticed about this study versus the other studies that we're going to review tonight is the power of this study is a lot more significant than the other studies. And basically the results you're interpreting from this are quite more profound, especially with the reduction of 31% in mortality among bleeding deaths if you're giving treatment within 3 hours. Also, a thing that wasn't really calculated within this study, but if you Google it, that is, the power of this study was greater than 90%, and so every single variable you're seeing for the relative risk is an approximate estimation. Let's see, for the bleeding deaths and those receiving treatment within 3 hours, we're having a 31% decrease in risk, and that's a very good approximation. And let's see, so basically what I have to say about this study, it's very valid, and it can probably be replicated due to how they did their baseline characteristics, and I'm going to look that up.
So
They
AJ,
have
can you hear me?
nearly no confound.
Can you hear me?
Yeah, I can
I
hear you,
have to
Dr.
talk to
Mullen.
him because of the
Oh,
microphone's-
so ask him to define for us relative risk.
So-
like this is like table 2.
So table 2 talks a little bit about relative risk. What's the definition of like relative risk, and how do we kind of apply it to our literature? And
So for bleeding deaths, it was
so for bleeding deaths, it
0.81.
was
So
0.81 in
just
the women
define
trial.
for everybody what 0.81 and
So
relative
the
risk
relative
mean.
risk is the probability of an event occurring. And so what they demonstrated with this women's study is that it has a protective effect by giving, because it's below 1, every relative risk is below 1, so therefore it has a protective effect. And although I wouldn't read too much into table 2 under bleeding deaths, the main relative risk is 0.81. However, if you change one case between the groups by a difference of 1, it no longer makes this value significant. And therefore, the main result of the study would be more profoundly the bleeding deaths and receiving treatment within 3 hours. And so you can basically just flip-flop it, and so you have 0.69, flip-flop it, and you'll have a 31% decrease in risk or probability of dying if you give treatment within 3 hours.
So that's a
kind of how you
69%
can
chance
see
of
that.
survival.
So 69% chance of survival, essentially.
No, it's 31% decreased risk.
Okay.
Because it's 100 minus 69.
100 minus 69.
Yeah.
Yeah.
And
Yeah.
so set like for thromboembolic events, it would be like a 12% decreased risk.
Can you hear Dr.
Yes.
Merlin? Okay. Yeah, he can hear you then. Okay.
And you can also call that a protective effect of using this medication versus placebo.
And since this is the first time
So-
you're joining us, can you just define like the, in parentheses there are the 95% confidence interval. Can you just define what the 95% confidence interval surrounding the relative risk means?
The 95% confidence interval is just going to say how far can our relative risk range. So for, let's say, for bleeding deaths within 3 hours, the confidence interval is from 0.52 to 0.91. So it's all below 1, which is great, because we're identifying a protective effect, which bleeding deaths definitely in 3 hours definitely is demonstrating within this study. And so it's just going to say how far the relative risk can range, and if the entire parameter is below 1, that's really what we're looking for. And as you can see with every other statistic in the study, every parameter is touching 1. So bleeding deaths within 3 hours is the only one that's not touching 1, which shows the most profound result.
So at touching 1 meaning because if 100 minus 100 is 0, so it's no decreased risk.
Okay, because any relative risk above 1 shows an increase in risk. Below 1, it shows a decrease in risk. So you can't cross the range, basically. Once you cross 1, it's no longer significant because you're on both levels of protective and modifying risk.
And that's specific for relative risk, though, confidence intervals only.
That's specific for relative risk, odds ratios, hazard ratios, and let me see. There's basically ratios and risks that you're reading in almost any journal.
Okay,
Okay.
that makes sense. So
Yeah,
so,
that really that sums it up. I mean, I never had that good of an understanding in medical school, but that just like put it into one sentence for me.
so it's theoretically possible that bleeding deaths, any cause deaths, or thromboembolic events, because it crosses one or touches it, could all not be meaningful.
Yeah, so you're talking about just bleeding deaths alone, right?
Right.
Yeah, so because it touches one, it's not as meaningful. And I even calculated the relative risk on my own. And if you change the placebo group to 190 and you calculate it again, the value is no longer significant. So even if you count for just a very margin of error of one case, bleeding deaths is no longer significant. So as a statistician, I can't really say that it's the most meaningful part. Definitely within 3 hours is demonstrating some significant protective effect of reducing mortality.
All right, that's good. You want to go to the next study?
Yeah, I can
That's
talk
great.
about
All right, we'll move on to the next study.
the balanced crystalloids versus saline in critically ill adults. I actually have two kind of components of this study. This was a pretty big study out of Vanderbilt. I remember, I think this was like early March, I remember getting ready for a long day on the road. And I literally heard this all
Did you
over
say
the
long
news.
day or fun day?
A long day and fun day.
Yeah.
But I heard it on like the local news and then the morning news, and then I heard it on the radio driving in. I was like, how is this study getting like press coverage and every single outlet? I was really, really impressed because I'm used to hearing like, you know, chocolate extends your life and cat wants to kill you, and study finds that alcohol is just as good as exercise. But like to get one about crystalloids, I thought was a very unique take. And so I actually looked up this study back in March, right when it was, I think it was actually before the press, is when all the news coverage came out, before it actually went to the publication, the New England Journal of Medicine. And so it was refreshing to kind of look over it and see it. Basically, this has been kind of a long-standing question, especially in critical care medicine, of should we use normal saline, 0.9% sodium chloride in sterile water, or should we use a balanced fluid like lactated ringers? There's others like Plasmolite and Normal Sol and Normal Sol R, and some others as well. But basically the question is does it cause harm? And there's been some big studies on it before, but a lot of them are OR-based studies. So really the aim of this study was to let's enroll a large group of patients and do an actual randomized controlled trial, patients getting the intervention, not getting the intervention, and let's see if we can power it enough to see if there's any difference. And one of the criticisms of the early studies was a lot of the patients only received a little bit of fluid, 500 or maybe a liter of the fluid, and was that enough to make a difference? And so really they actually excluded some of the people who only received a small amount of fluid. That was one of their exclusion criteria, is less than 500 cc's of fluid. So we're looking at, does these large amounts of either saline or balanced crystalloids make a difference? And so let me just kind of go through some of the stuff here. Basically, the inclusion criteria was any adults 18 years of age. They had to receive at least 500 or more. They had to be admitted to the hospital outside the ICU, because the ICU patients are going to be a separate part of the study. And they couldn't be people with ESRD or on hemodialysis, because one of the primary outcomes that they're looking at on this paper is there adverse renal effects of these fluids? Kind of that's our best guess of what the harm would be. And so they set out with the goal of looking at, does this harm the kidneys? And they also had secondary outcomes of in-hospital mortality. Did they have a rapid response in the hospital? And did they have persistent renal dysfunction after their hospital admission or through the rest of their care? So what did they look at? They actually had quite a bit of patients. They had people, let's see, let me pull up the actual numbers here. They had 6,708 patients that received the balanced crystalloid fluid, and they had 6,639 patients that received the normal saline arm of fluid. The median volume of crystalloid that was received among these patients is 1,079 ml, so a liter, just over a liter, but with the range up to 2.5 to sometimes 3 liters of fluid. 33% of the people got more than 2 liters of crystalloid. And so then they kind of looked at what were the results, what was the outcome. Oh, and an important kind of caveat of this study as well is that there was one exception, even though it was a randomized controlled trial, so that the patients who were getting the fluid was decided beforehand, randomized, with the exception of patients with traumatic brain injury. So if the patient was known to have traumatic brain injury, they could still be included in the data of the study. However, the physician could decide this patient might benefit from normal saline because of its hypertonicity and its possible benefit. So that's one group that will be kind of left out. So what did they find? Looking at their statistics table, they kind of had a lot of statistics and factors that were not statistically significant. And I think that was really smart of them to go into this with the stated goal of we want to look at the kidneys at 30 days, because otherwise it could definitely have been this study showing, well, there's all these, even though it's equal groups and it looks like a representative sample, there was a lot of things that they looked at, like in-hospital deaths and ICU-free days and how many ventilator-free days, and all of when you compare the two groups, they basically weren't statistically significant. So what did the authors basically find through the I'm sure complex stats of this paper because of the amount of data? They basically showed that lactate, normal saline does seem to harm the kidneys, but the amount it harms the kidneys, or at least the amount that they showed in these two groups, was really a difference of around 1%. So I believe it was 14, let me find the numbers, 14 and 15% of people with acute major adverse kidney events within 30 days, and the balanced crystalloid, 14% of patients, and in the saline group, 15.4% of patients that was the one that had a p-value of 0.04, showing it was a statistical difference. And I think that makes kind of intuitive sense from all of the other information we know about fluids. So we know hyperchloremia is bad, and so giving these patients tons of extra chloride and is physiologic is bad. And we know that normal saline fluids are acidotic, slightly acidotic, and we know that acidosis is bad. And so it makes kind of a sense on a lot of levels that this probably does have some bad outcomes, especially in people in the ICU or the OR who are receiving massive amounts of fluid. So that's what it did seem to show, although I don't know that the effects were as great as everyone kind of expected, especially when we had these high powers and these large volumes of fluid. However, I think it's still, at the end of the day, the question always is, well, why do we use saline? And I don't think anyone has a good answer for that. Tradition, I guess, is the right answer. Tradition, because it's not really cost. Lactated ringers and saline are almost identical, like literally pennies difference. Certainly some of the other balanced crystalloids, they are more expensive, but lactated ringers is a balanced crystalloid that is not expensive, and that could be used. As a side effect, because when I started going through this article, the other thing that always comes up is, well, could we switch over to just all lactated ringers? Maybe everyone in the ER, and therefore by extension everyone in EMS, should they receive lactated ringers? And the exclusion patient that's always going to come up is, well, what about renal patients? What about people who are coming in hyperkalemic? And at first blush, that makes sense, right? Because normal saline has no potassium in it, and lactated ringers does have some potassium in it, a small amount. So then I actually started looking in some of the other articles that have been published around this topic, and it actually shows that normal saline can increase your potassium more so than lactated ringers. Number one, because the amount of potassium in lactated ringers is very, very small. And also most of the potassium in the body is stored within the cells. So by the time that you have extracellular or in the blood potassium, that's the problem potassium. So by giving fluids, and especially when you're giving fluids with very low potassium, you're actually shifting it into the cells. And by expanding intracellular volume, but therefore decreasing potassium. And because lactated ringers are a little bit buffered, that reduction in H ions and the acidosis also reduces your potassium much, much more than the tiny, tiny amount of potassium that is in the fluid would contribute to increasing your in the blood potassium. So I thought that was another reason. Basically, that's kind of the only holdout of why we would not necessarily give lactated ringers, and that's kind of as I kind of new news to me, doesn't seem to be a good argument anymore. So if we're having these bad outcomes, maybe we shouldn't be using saline. I don't know if anyone had any more.
So if we're blaming the kidney, acute kidney injury, it says here that the incidence of persistent renal dysfunction was 6.4 versus 6.6%, which is not statistically significant.
Right.
So how can we blame the kidney when the persistent renal dysfunction is not changed? I understand the in-hospital mortality is different, although be it less than 1%.
Right.
So is it the kidney?
That's a good question. I don't know. I think that's where everyone was banking. We had all these small studies that showed that these are some of the bad parts of normal saline. Maybe if we have a powered enough study, we'll show that it is. And I think they were banking on that it was going to be the kidneys, even though they had the secondary outcomes of like in-hospital mortality. I'm not sure. Yeah, I don't know.
And
but
how much fluid did you say that they gave?
they had to receive at least more than 500. The median was just over a liter, and many patients, 33 patients, got more than 2 liters.
And that was as a bolus.
That was as a. Actually, I don't know if that was as a bolus. Let me see if they defined that. I'm not sure they defined that. I'm trying to look and see their actual.
And did they
methodology.
include pre-hospital
But I would
fluids?
suspect.
Because we tend to do a very bad job when we decide how much fluid to give people, including
right.
the pre-hospital amount.
Especially with the 30 cc's per kg rule and our 200 kilogram patients, it kind of makes a big
Right,
difference.
we exclude what they got pre-hospital, which doesn't make sense for the made-up 30 per kilo anyway.
Right, and they don't specify whether they included that, and I can imagine just from my own experience that would be hard to include, and maybe that's why they didn't address it, and they only used the data they had, which would be easy to pull, being the ER data, because all of this data was from one hospital system, and that's why they were able to kind of easily mine it. So I suspect that they didn't, although that hospital system does have their own EMS, so presumably they could have gotten it. They just didn't mention whether they included that.
And usually when you bring in a patient, you have the bag hanging, and they could easily add it, but I don't see them adding it. Like you don't see in the report like, oh, patient already received 500 or.
I mean, this has been written about a lot in throwaway journals, but I fundamentally have difficulty believing this. I mean, it's a small difference, but I just think clinically, there probably is some patient who maybe one fluid is better than the other, but that patient might have systolics less than 60 or already have pre-existing hyperkalemia. I'm not sure they looked at pre-existing hyperkalemia. Or there's got to be something about them that you just can't, there's just too many confounding variables on these patients. There's got to be something with some blood test that's just making them a little bit different than the other group, or there's just certain patients that this is true and not others. It's definitely an interesting finding. I wouldn't have guessed it. I just think this just is the kind of thing that makes us go, it doesn't give us a clinical answer.
Right. I don't think it gives us a clinical answer, especially when the data is so close, and it should have been powered to give us a better idea of this.
It probably does make me feel a little bit better than about lactated ringers. I must say
that's where I landed. So I thought that that's exactly what happened to me. I thought that this would be like, oh, saline's terrible. Reading through it really seems, no, it's probably okay for pretty much everybody. But what it did do is like, oh wait, I've been scared from lactated ringers for all the wrong reasons. Actually, I probably shouldn't be using this. And I think the limiting factor of why we don't use it more is just it's not right next to the saline. The saline is literally right on the desk. The lactated ringers, if they were next to each other, I probably would grab lactated ringers more.
But Bob, how are we, so the cost is exactly the same?
It's relatively the same.
And how are we with shortages of normal saline versus lactated ringers?
They're both in shortage because of the manufacturing issue in Puerto Rico. But we have more ringers than we do saline. And if we run out of the 500 bags, we're gonna have 1,000 bags of saline. So if we're gonna have 1,000 bags, ringers is just as good.
Dr. Westrow from watching on Facebook online, one of our faculty members has a question. He's asking, would severe sepsis bolus quantities of lactate and ringers affect lactate levels?
So no is the answer. right? Because it's not lactic acid that's in the lactated ringers. It's buffered lactate, which is different and metabolized differently. And so no is the answer. Well, I mean, it will decrease your lactate because you're giving fluids. But to answer your question directly, no.
Right.
It will decrease your lactic acid if there's septic, and you're making them better.
Right, that's what I mean,
But for
if you're making them
ongoing
better.
people who have
As a-
like mesenteric ischemia or something,
Right.
that would be very
Sure.
difficult to tease out in the study, right?
As a resuscitative feature of the bolus itself, it's going to affect lactate levels in a positive direction. However, the lactate specifically does not get skewed, I guess would be the right word.
On the other hand, if you give them 30 per kilo and they're not hypertensive to start with, you're going to throw them into failure, and CHF increases your lactic acid. So
Sure.
that will be confusing too.
Sure, sure.
Isn't that the Corey cycle, where the lactate
Yeah.
gets converted to lactate
Yeah, yeah.
acid? In
But
the-
you were a
in the liver?
biochemistry major, right?
Yeah, yeah.
We're on a 12-second delay. Does that answer your question, Dr. Westrall? I have to wait 12 seconds now?
Buffering, right.
Yeah, yeah. So how about some statistics, AJ? What did you think?
All right, so we're comparing both studies at the same time. I forgot because, let's see, we're mainly are we going to compare the critically ill and the non-critically ill statistics together at the same time, or do you want to separate it?
We can do both.
You can do both.
Yeah,
Yeah, you can do both, and then we'll just summarize the non-critically ill, so afterwards.
Okay, because I mean, obviously they had a trial, they did a big trial, and they just made 2 papers out of it. And so let's see, I'm going to go under the critically ill statistics. And they used logistic regression to do most of their analysis for the clinical outcomes, and adjusted for, let's see, in-hospital death. Let's see, in-hospital death, recipient new renal placement therapy, and final, let's see, creatine level at greater than 2% of baseline. Let's see. I found something interesting about this, because I don't see them giving their baseline odds ratio, unless you guys are seeing that. Do you guys see a crude odds ratio? Yeah, I don't see a crude odds ratio for this.
Maybe AJ, since it's our first time with you, maybe can you just define the odds ratio?
The odds ratio can be interpreted a lot like your relative risk ratio, or your basically, like I said on the other study, it can be interpreted quite the same. If it's below 1, it's going to have a protective effect. You're decreasing the risk. And so if you see 0.9, you have a 10% decreased risk of that occurrence, and that's what we're seeing with major adverse kidney event, is a 10% decreased risk. And I'm actually going to calculate let's see, table 2, clinical outcomes, the critically ill, the crude adjusted is 792. Kind of just want to calculate this real quick so I can have something to play with. And 7860. Let's see. Yeah, so their crude odds ratio was 0.93, so they had a 7% decreased risk, and then they adjusted for all of these risk factors and decreased it to 0.10. So what I was semi-assuming with this logistic regression approach is maybe they actually didn't truly modify the protective effect at all within the study, and I found it to be an interesting concept that might need to explore more, and basically take the major adverse event within 30 days with balanced crystalloids with a grain of salt in this study. That was my main inference. And let's see. Do you guys have any questions with the statistics?
So like on table 2 for the critically ill paper, so just to define it, so like it says final creat on the left column, final creatinine level greater than 200% of baseline. So the adjusted odds ratio says 0.96. So just say how you would, like in English, what is 0.96 and the confidence interval mean to you?
Okay, so 0.96, it technically states 4% decreased risk. However, because 0.84, you have to look at it on a continuum with a number line, and since it's 0.841 and 1.11, one's always there, by the way. And so since it crosses that, it no longer shows any significant difference. And what this might show is that the greater than or equal to 200% is not a potential confounder with the primary outcome.
So, like, I've always been confused, like in papers, do I have to list my p-value? I find many papers list the p-value and the odds ratio or 95% confidence interval. But isn't it like saying the same thing twice? I mean, if your p-value is not going to be statistically significant, if your upper limit of your 95% confidence interval hits 1, right?
Yes. It is very much like saying the same thing twice to a point. What changes a lot is when you have an increased sample size, like we do with this study, the difference between the lower bound and the upper bound will be smaller. So confidence interval reflects your sample size, and that's usually why you report it within a study. It's because you just want to see how much your risk is going to vary. And that's usually why you report that and the p-value.
So, like, for major adverse kidney events within 30 days on table 2 of the critical paper, so just tell me how so 0.90, tell me again how you translate that.
I would translate that as 10% decreased risk of a major adverse kidney event among those with balanced crystalloids compared to those with saline.
Right, and the upper limit's 0.99, so...
Yeah, so that's why I was referring a little earlier on that if it's close to 1, it's kind of taken with a grain of salt to a point. And I noticed how let's see, yes I did. Let's see. So the crude odds ratio for major adverse kidney event, if you calculate it, is actually 0.85 to 0.101. So it crosses 1. And when they adjusted their analysis for these other covariates, it decreased the risk just marginally, which made it significant. So they ended up pushing the parameter a little bit to get the value, in my own interpretation.
Oh, so if they hadn't adjusted that, it would have been no difference.
Yeah, I have a theory that if you took out final creatine level greater than or equal to 200%, your p-value would no longer be significant for major adverse kidney event. Out of the logistic regression model.
I wonder if they were planning to adjust it from day 1, or they were adjusting it after they got their results.
That's the question.
Let's see. Did they talk about interim analysis
I
in the
don't
paper?
think so, did they?
Let's see. They conduct.
I believe they did do an interim. I don't
interim
remember where I saw
analysis.
it.
So they probably did. Yeah. They probably found the effect and adjusted for it and reported it.
I mean, in the subgroup, there's an analysis where they have the odds ratio, like the better balanced fluids, they have the graph, and I guess we can see what crosses 1 and what doesn't.
Mm-hmm.
But not all that much is greater than 1.
Yeah. Let's see. Do you have any other questions about the differences between the two studies and statistics?
No, I don't think anybody has any questions.
Good.
That was great.
Okay.
And then, is there anything else we want to say? What else do we want to say about the non-critical?
So the summary of the non-critical is it used the same data and basically looked at different the different subsets, and it found no difference. Basically, they were the same. And I guess they answered that, number one, because they already had the data and probably that question was going to be asked, and it was easy to just pull that answer out. But I think that probably was what they were expecting anyway, that there was going to be no difference, which is why they powered it for all of these critical patients, and they powered it with high volume fluids. So that I think that makes sense. I really don't think there's much more to say about that. They published them together, I think, just to kind of so that people could look at both at the same time.
So the unadjusted odds ratio crossed 1, but the adjusted odds ratio didn't cross 1. Is that right, AJ?
Yes.
So tell me, like, as a statistician, what it means to you when you adjust an odds ratio or like relative risk. How are you doing that mathematically?
Mathematically, to say it really quickly would be kind of complex. Basically, they just put another value into the model because it would be you have your outcome of mortality equals how many other variables you want to put in the model, and it can rotate depending, because logistic regression works on the principle of Bayes' theorem, and Bayes' theorem changes upon different probabilities that you enter into the model. So if more probabilities you enter into the model have a reduced risk effect, it'll pull down the entire model with it, if that makes sense.
Yeah. But when you adjust, you certainly don't know which way your confidence interval is going to go, right? I mean, it could have crossed 1, but it could have gone the other way.
Not depending on if you look at your data set and kind of interpret it. Like I said, they did 2 interim analyses, so that makes me think that they kind of knew what they were doing, and they were trying to find a significant value.
Right. Interesting. Sorry, keep going.
No, I mean that's really, and I think so. When I looked at this paper, that was my same impression. I was like, wait, all this like commercial layperson press for this, like this isn't even that much of a result. And now hearing this and hearing about the adjusted odds ratios, I think that even is more so. Right? But maybe this is
Depends who your PR guy is.
right.
Right.
It depends on how you're selling it and.
I mean, so they had to get at least 500 of fluid. Does this do anything for us in the pre-hospital setting or in the emergency department? I mean, everybody always wants to give a fluid bolus to patients, right? I mean, and I don't always know why.
I feel like you need to do something.
yes.
It's just, patient
it
has a
makes-
complaint. Give them some fluids.
Or if they're tachycardic.
I think there's a placebo effect,
I mean, everyone feels better after a liter of fluid.
Right. I mean, the truth is, some people feel better after fluids because we're getting rid of ketosis, but we do that by giving a dextrose-containing solution.
Not normal saline.
Right. So for me, I always have traditionally started out with normal saline, and then I've switched pretty quickly to D5 normal, because D5 will get them out of ketosis. So it's sort of like the woman who comes in with a hyperemesis gravidarum who's vomiting her brains out like over and over. She feels terrible, but she probably feels terrible not necessarily because she's volume depleted, because you get volume depleted much easier from diarrhea than vomiting. There's this famous fluid guy at NYU called Lowenstein. He's a nephrologist. And his mantra for years has been, you cannot get volume depleted by vomiting alone, unless you have a bowel obstruction or unless something is critically wrong with you. He's very interesting. And he's written all these books and papers about volume depletion. So I think, women with hyperemesis gravidarum are the perfect example. They're vomiting like crazy, and what's their blood work usually? It's usually very normal, right? And when we get them better, it's because we're giving them a dextrose-containing solution, which is getting them out of ketosis, and that's why they feel better, not because they're volume depleted to start with, right? So you need a dextrose, you need some sugar, you need a dextrose-containing solution to get out of ketosis. But people don't do that. They just give like normal saline for like 2 liters and then call it a day. And it really doesn't make any sense. And the other perfect example is alcoholic ketoacidosis. You need a dextrose-containing solution. How many people have AKA? They go to the emergency department, they get 2 liters of saline, and they get admitted to the hospital. When they have AKA, they need a dextrose-containing solution, right? Okay, you want to do the next one?
Peri-intubation hypoxia. That be the next one. Okay. Great study. Let me put up the image. So this was an EMS system that implemented a clinical bundle to reduce out-of-hospital peri-intubation hypoxia. So let me just put the image up here on the live feed. Okay, there it is. So we've talked about this a lot. Essentially, I always reference that first article you made us read, first article ever of fellowship. For all of the fellows who come to do the New Jersey EMS fellowship, you will read this article by Scott Weingart, Rich Levitan, and a few others, right?
And I would say if you read the article like 5 times, you'll be more than 90% of doctors.
Yes. So this was, in many ways, I think, a great confirmation study to the practices that we should all be doing when we're intubating patients. And essentially, we know, so this was basically Jeff Jarvis et al. Out of Texas, Williamson County EMS in Texas. So essentially, hypoxia, it's certainly something that we can see in intubation, especially if a patient's not pre-oxygenated. We've talked about that ad nauseum. But if you develop hypoxia in intubation, we already know you can be associated with bradycardia, deterioration of bradycardia, and ultimately cardiac arrest and increased mortality. Multiple studies, they quoted 3, have shown that. So in the emergency department, up to 36% of RSI has been shown to develop hypoxia, and 57% in the field. That's enormous. So, and a lot of the times the providers don't even recognize that it's happening. We've talked about pre-oxygenation before and an attempt to create a reservoir of oxygen for patients who are critically ill in getting intubated. And even if they're not critically ill, somebody who's getting intubated, let's say for trauma or because they're jerks. No, I'm just kidding. We don't intubate patients because they're jerks. They're, washing out essentially the nitrogen in the lungs and displacing that with oxygen, so you have a reservoir. So a lot of optimization strategies, so including apneic oxygenation. We've talked about that before, right? Taking a nasal cannula, turning it up to 15 liters per minute. Patient positioning is another one. Head up, right? Ear to sternal notch. We talk about all these things when we're learning
15
how to
liters in a
intubate.
pre-hospital setting, higher when you have access to humidified oxygen.
Right. And the use of the bag valve mask appropriately in a patient, so by using positive end expiratory pressure. So that's a PEEP valve that we add onto the mask. So, and also delayed sequence intubation. So I don't think we do this one enough. That's basically the use of ketamine or sedative to facilitate relaxation and therefore pre-oxygenation prior to intubating a patient. So, you get those people who are altered or who are ripping off the BiPAP mask or very uncooperative. And those are the patients who are going to desat or destabilize on you because you're going to rush into the intubation. Those are the ones that you put them into the K-hole a little bit and let them breathe on their own and fill up their lungs with oxygen before you proceed with the paralyzing and then the intubation. So this is something very important to the ED, to pre-hospital. Basically, this study, the goal was to determine the effectiveness of introducing a clinical bundle where this bundle consisted of patient positioning, apneic oxygenation, delayed sequence intubation use, and then goal-directed pre-oxygenation. And basically all as a prevention measure to reduce the number of peri-intubation hypoxia patients during out-of-hospital intubation. So essentially it's a before and after study. We've done those before. This was like a quality improvement project that they instituted, and they looked at their data before and then after the institution. So as we mentioned, it was Williamson County in Texas. There's a population of about 500,000 people in central Texas. Do you know where that is, Tagore?
Central. Texas is very large.
Central Texas, that's all we can say. And they actually have a system where they're dual paramedic crews. That's something we can relate to in New Jersey, who are dispatched for certain calls. And the selection of participants, they looked at all non-arrest patients. Pre-protocol or pre-introduction of this bundle was October 2013 to December 2015, and then after introduction of this protocol was December 2015 all the way up to July 2017. That's the after period. They took out all patients in cardiac arrest, I think rightfully so, because they are potentially going to be hypoxic. And that might be because they're just not perfusing their tissue. So they looked at the interventions, including high flow oxygen through a non-rebreather or bag valve mask, which we can do, and a nasal cannula, both of those together, and administration of ketamine or and succinylcholine in RSI. So ketamine plus sux or ketamine plus rock in RSI. So they use ketamine for all their RSI. Yep, that's great. Great drug. Before the protocol was instituted, pre-oxygenation was encouraged but not required. After they introduced the protocol, they essentially made it a requirement. You cannot proceed with the intubation until all other elements of the bundle were completed, and they checked it off. I think that's amazing. So checklists are great. So they did the clinical bundle. They had placement of the patient in the head up, ear to sternal notch sniffing position. We've looked at individual studies where they tested this and they demonstrated better outcomes in terms of less peri-intubation hypoxia, right? So it makes sense.
So who are these guys? You're doing everything right.
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 Apneic oxygenation, delayed sequence intubation.
Williamson County EMS, Central Texas.
And I think they started in 2015 with this bundle.
Mhm.
Congratulations.
That is
26,901 responses.
So then ear to sternal notch, so, face in the sniffing position essentially, so lay them back but have their face parallel to the ceiling. Oxygen flush rates all the way up through the procedure. Delayed sequence intubation, in which was used, essentially they sedated for at least 3 minutes until pre-oxygenation goals were achieved. And their goal-directed pre-oxygenation, that means that they had to pre-oxygenate for at least 3 minutes, and then they needed a pulse ox greater than 94 before they could proceed. They couldn't even proceed with the intubation. They would abort the intubation if they were not able to achieve hypoxia. And the patients were probably de-enrolled from the study if they ended up getting intubated. So, I think that's pretty much it in terms of their protocol. So in terms of the training that went into this, there was a 2-hour lecture that all the paramedics got, and then a 1-hour hands-on session, and they had monthly re-lectures, and they address this monthly with the paramedics to kind of reinforce the protocols. Let's see, methods and measurement. So kind of talked about this already, but the protocol, one thing also, so the protocol required continuous waveform capnography in addition to pulse oximetry, blood pressure management, and then EKG monitoring. So they all kind of monitor this as outcome points. And if you look at table 1, they have just basically a summary of all the before and after groups, the requirements or the points that were present in each group. The before group had non-rebreather, ketamine plus paralytic, apneic oxygenation, intubation, which were suggested but not required. Afterwards, all those elements that we talked about are included and required to proceed with intubation. So. And then they just have definitions in Table 2, which you can read on your own. They're pretty straightforward. Their primary outcome that they measured was proportion of patients with peri-intubation hypoxia. And that was basically anything below 90% occurring anytime during intubation attempts, at any time during the intubation. So, and primarily they were looking for hypoxic events during laryngoscopy. So it they didn't really include patients who are hypoxic after the completion of the intubation, after everything was done. And secondary outcomes that they were looking at was peak and nadir oxygenation saturation values. I think that's a weird word, by the way. I don't know. We don't use that enough. And as well, they were looking at other things like bradycardia and then cardiac arrest. So let's see here. So essentially, they had the before and after groups. The group for before in Table 3, if you're following along, ended up being 104 patients, and then the after group ended up being 87 patients. And I'm sure AJ will go into this a little bit more, but what I usually do when I'm looking at one of these tables with multiple outcomes, first I'm going to look for the primary outcome, and I'm going to scroll down the difference and then the confidence interval to see what was important to me. So, for example, the peri-intubation nadir pulse oximetry median had a difference of 5, and the confidence interval is 2 to 10. So, things like that, big differences and different confidence intervals. So Anybody ever seen a waterfall plot before? Maybe once we switch over to AJ, he can talk about this, because in the figure there, the only figure in the article, there's a waterfall plot. I can't say that I was comfortable really reading it.
It's not a typical plot we use.
This is
Journals.
probably the first time I've really seen it. So.
I mean, it looks pretty.
It looks strange to me. Keep going.
Yeah. So let's see. Essentially, the table 4, they did comment on a few other reasons that they aborted intubation. There were a few attempts where they had to abort the intubation. For example, if you lost your pulse oximetry signal, you can't really comment on that as a patient in the study. And inability to achieve pre-oxygenation, if the patients were hypotensive, if they did not attempt resuscitation, if there was no reason given, for example, or if they just did not have all the data. So ultimately they aborted intubations in 18 patients altogether. So essentially, let's see. They were only unable to achieve pre-oxygenation goals in 5 cases. That's 4.7%. That's pretty good. In all patients who got the bundle, only 5% they were unable to pre-oxygenate. I think that's pretty good. So essentially, maybe there was some kind of a pathophysiological condition that was pre-existing. They was unable to exchange oxygen or something like that. Or maybe they intubated the esophagus and just didn't realize it. You never know. Patients, so essentially, I think, just long story short, this clinical bundle that they introduced, so patient positioning, apneic oxygenation, delayed sequence intubation, goal-directed pre-oxygenation, and just the goals to avoid hypoxia were really shown to have a positive benefit on the patients. Really, though, I mean, that's one of the big limitations of the study is this was not a randomized controlled study, right? This is all retrospective, a before and after study. So if you want to get a good look at the patient outcomes and patient-oriented outcomes and pragmatic study, right? So those are all things that we want to see in a good prospective randomized trial. So maybe we could do that, but I think in many ways you'd be harming the patients by not doing all of those interventions during an intubation. So I'll stop talking because my voice is kind of getting monotonous, but do you anybody comment on that before I switch over to AJ? I think everything they're doing in that county is
It's
great.
kind of impressive.
Yeah, this is like north of Austin, actually. It's home to the city of Round Rock, which is famous for their Round Rock donuts, which are like this big.
All right.
Yeah. So AJ, let's switch over to you and see if you have anything to say about this article.
So I mean, this one is quite a lot different in how they're comparing the groups. It's a pair difference testing, so you take a group, you analyze them, and you test them, and you see how they did after. And I did notice one thing quite profound about this study was the amount of skewed data they had within this data, or like extreme values. And if you go to the waterfall plot on page 5, you can see the box plot on the right. And that box plot on the right shows you before and after how drastically things are skewed. And if it doesn't fall within the ranges of the box plot, it's a skewed value, and or also called an outlier. And you can pretty easily visually see that the amount of outliers and that we have within the study is very drastic. So the waterfall plot may not be the best approximation to see the before and after differences because it exaggerates the before and after due to the drastic increase of the outliers versus the people who are within the box plot themselves. Does that make sense?
Yeah, so if you were picking what kind of plot to use, what would you have picked?
If I was picking what?
Like what type of a graph or plot to show the data, what would you have chosen?
I mean, personally, if I was running the analysis, I would probably do, I'd need to run diagnostics to see the potential outliers, and if I can adjust it anyway to start eliminating those potential outliers. Maybe that confounding, if I know the patient characteristics more in depth, I could eliminate them from the study altogether to just eliminate that skewness that's manipulating my trial, especially with the before group. The before group has a drastically ranging oxygenated differences. And so if I adjusted, the waterfall plot would still be fine. I'm mainly saying that when you look at the waterfall plot in this study, you might want to take it with a grain of salt due to the fact that they have such extreme outliers within the study. And that's why they're using median testing to adjust for these potential outliers. They're just looking at everyone in the middle.
All right, so that makes sense. So in table 3, like, we don't have p-values in this study, and we talked about for relative risk and odds ratio that if it gets to 1, it's no longer significant. So what can you tell us, like in the table 3 in the difference column of those confidence interval ranges? Like, what ranges are, better for us than others?
Well, if you're not taking patient characteristics into account, you're just talking about intubutation characteristics.
Yeah.
Let's see a value. I'm trying to identify first pass success. I don't know what that means.
That's basically the when you're trying to intubate somebody, if you're successful in the first attempt, that's your first pass success rate. So it's usually a...
Okay. So as you can see with first pass success, this is going to be chi-square testing they're doing for this value, because it's the number, it's the frequency of the count. And they found a difference of 3.9 percent difference, because that's a 8.46 minus 8.51 is 3.9. But as you can kind of see with the confidence interval to the right of that, it goes from negative 0.58% to 13.5%. So the range is entirely obscure because of the outliers within the study basically just messing up your results. And that's most likely why they didn't report a p-value, because p-values would have shown extreme significance, which would have been ambiguous to the study.
So because the lower 95% confidence interval is negative 5.8, can I make the assumption that first pass success was sometimes better before and sometimes better after?
Let's see. Yeah, it was better in the before group than the after group. And that's just by a margin of, hold on, never mind, sorry, better the after group than the before group. I was reading this backwards. And it's just by a margin of 3.9%. But that confidence interval can still go negative and positive, which basically shows you that it's not very significant.
Right, so anything that's negative or positive, we could say is not significant. Which is,
should be, yes.
Which is most of them.
Yeah, and that's mainly due to the potential outliers, and that's why I was saying diagnostics should have been run to try and eliminate the potential outliers through some sort of coefficient of determination or some other value system that you want to eliminate them on. And I don't think they did that within the study. They mainly just demonstrating the descriptive statistics among groups.
So, I mean, correct me if I'm wrong, but I was always taught to look for the narrowest confidence interval possible that doesn't cross over to the negative range. Is that accurate?
Yeah, exactly.
But then sometimes when I eyeball what a wide or narrow confidence interval is, it's just very challenging to figure out how big a confidence interval is too big.
Yeah, that's why I was saying that I personally don't really enjoy reading Table 3 because it's quite hard to, because you have to keep referring back to what you're looking at for each variable of characteristics. So unless you exactly understand statistics, the interpretation is going to be quite time-consuming to digest it all, which is why diagnostics, if you ran that, deleted the outliers, then gave a p-value, it would have made just the interpretation of the table way faster.
Yes.
Okay, anything else, guys, with this? Okay, want to go to the next one?
Yeah, the next one was the, time to epinephrine administration and survival from non-shockable out-of-hospital cardiac arrests among children and adults. This was in Circulation, and it basically was a review of the Resuscitation Outcomes Consortium Network over 4 years, which basically is a database of a large group of participating EMS agencies, and they were able to actually pull out 55,568 EMS treated out-of-hospital cardiac arrests. So basically, they were able to use this big data set to see and dive down and look at, what can we do and what will make differences in these cardiac arrest outcomes. So what they did here is they looked at only patients with non-shockable rhythms. So patients with shockable rhythms, being VFib TAC, were excluded. They also excluded, interestingly, those patients that had return of spontaneous circulation in less than 10 minutes. I thought that was kind of an interesting thing to exclude, although I suspect they mean return of spontaneous circulation within 10 minutes of cardiac arrest, because one of the variables they're looking at in the study is they're looking at time from EMS arrival to, and that being time 0, to time of epinephrine administration after EMS arrival. So they're not actually time marking it back all the way to cardiac arrest, but really as it relates to EMS arrival on the scene. They looked at both adults and children, and then they looked at each of the subgroups too to see if there was any difference. The primary thing they were looking at was there a difference in the amount of time it took from EMS arrival to get epinephrine on the effect of walking out of the hospital alive. They also, and the way they looked at that is they put all these cardiac arrests that were non-shockable rhythms into 2 groups: people that got epinephrine early and less than 10 minutes from EMS arrival, to people that got epinephrine for the first time late, greater than 10 minutes after EMS arrival. So like I said, they looked at 55,000 people. 32,000 of them were initial non-shockable rhythms and were included in the study, which is kind of an interesting also just mark that what is that, like 60% or so of these patients had non-shockable rhythms, of people, of all comers. And then there was 12,000 people in the early group and 14,000 people in the late group, so we're closely similar. And interestingly, 5,346 people that had that did not receive epinephrine in their cardiac arrest for unidentified reasons. And what they found is that after doing the odds ratio adjusting, they found a 4% decrease in odds of survival for adults for each minute of delay from EMS arrival to getting epinephrine. First of all, from the perspective of things that should be flashed on the news in like late mainstream public, hey, we have increased people that live and are not dead. You'd think that would be more like important than we should rebrand fluids to use lactated ringers. Exactly. I always thought that was so interesting. But as far as the study goes, also kind of intuitively, this kind of makes sense, right? So first of all, we're not talking about people that have shockable rhythms, because we know that treatment, it's electricity. It's people that don't have shockable rhythms, so presumably the cause of cardiac arrest is something else rather than massive MI inducing a VFib or VTAC. And it's smart that they excluded those people, because probably those people are being harmed by early epinephrine, right? You give a abnormal heart rhythm epinephrine, you might send them into a refractory VFib or VTAC. So now we're looking at people that have their cardiac arrest from other cause, and if I had to guess, just anecdotally, a lot of these people are going to be like hypovolemic arrest or septic shock arrest, where epinephrine might help them. So their outcome of people that got epinephrine earlier is better makes sense. Also, it makes sense that people that got epinephrine earlier might have had more resources on the scene. They don't attempt or mention if they tried to adjust for that potential confounding factor. In addition, people that got epinephrine earlier also presumably had the other intervention of cardiac arrest earlier. They don't mention it. That's why I think it's so interesting that they excluded people that had ROSC less than 10 minutes, and they don't exactly define it, but I suspect they mean less than 10 minutes from their cardiac arrest episode. So I think it's a flashy headline, 4% decrease in survival for every minute that you delay epinephrine from EMS arrival. I think that makes kind of intuitive sense, right? All of this stuff is time sensitive. The CPR we know is time sensitive. The delaying the important parts, CPR, and figuring out the cause to do an intubation or another procedure makes sense. It is harmful. I think it adds more information, but I don't think it is, we should give epinephrine as the first thing we do on scene, because that's not what it was looking at all, right? These are people who are already getting CPR, and they excluded people who had fixable reasons, right, shockable rhythms, or they had witnessed arrest and they were able to be turned around quickly and they had a ROSC less than 10 minutes. These are people that were already kind of refractory or may have been already far down the pathway of acidosis and the triad of death because of this long delay of getting EMS and then getting your access and then getting the epinephrine. I think the one thing it probably does, should infer though, is that messing around trying to get access and trying to get 17 IV attempts rather than one quick IO and making sure you have a good IO, that probably makes the difference in some people. So I think it was more intuitive than what I thought it was going to read as when I started reading the title as, oh, quick epinephrine is better. But I don't think that's what it necessarily is saying. It's quick interventions are better, of which epinephrine is one of them. And then when you exclude the people who we can easily fix with electricity or another mean, yes, that makes sense. If we should not stand around and delay CPR, we should not stand around and delay epinephrine. Mm-hmm. I don't know if you guys have any other thoughts on that, but I think that the title is misleading because I think it says, oh, this person's in VTAC, we should rush to give them epinephrine. But that's important to mention that, no, these are not the population they're talking about.
Right, not at all.
So how many people survive if epinephrine was given? What was not the percentage, but the actual number? How many people survived if epinephrine was given less than 10 minutes?
Let me see if I can pull up their actual table here.
Because I came full circle from this article. When I first read it, I thought, what is this going to teach me that I don't know? And then I thought, well, 55,000 patients is a big database.
Right.
So it's a lot of patients.
I think that's the other potential confounding factor of that is, it's the best data we have, and so we're adding power to try to work through that data, but it's innately flawed data because this is retrospective charting by EMS, and as we all know, these are estimate times. So saying there's a 4% difference based on a minute, well, all of these minutes are estimations, and so, well, crap, what time did I give the epi? Did I remember to push the monitor and mark the time exactly? Probably not, because I don't ever remember doing that. But it's kind of what we have to work with, so we got to make it. Let me see if I can find the actual specific number.
For asystole, it was 8,368 patients with early epi. So of that 8,368, what percent survived? Was it 3%? What was the number?
I'm trying to hone in on it here.
Because I wonder what, how clinically significant the actual numbers are. It is impressive, though. It is something.
Right.
When epinephrine, to me, has always been a drug that doesn't work, or at least it causes more ROS, it just doesn't change outcomes. Maybe that is because we're not giving it fast enough. But that's so much for the theory about beta blockade and tachydysrhythmias with epinephrine making people harder to shock. Of course,
but
that isn't VFib.
But they excluded all those people from this analysis.
So maybe it's the VFib VTAC that shouldn't get epi,
right,
and maybe PEA and asystole should get epi.
Right, which kind of makes sense to me, right? The PEA is meaning you're missing something, and probably one of the most common causes was going to be like a septic shock just by volume of the
and the
national
VF
population.
pulses VT is a tachydysrhythmia.
Are
they really telling me that
right,
asystole, you have more survival in asystole? How many people survive asystole?
Or
less than 1%.
Yeah,
in this study?
No, in all, and I think
but
all other studies.
Well,
also,
I mean, the survival from asystole is closer to 0%.
I'm always, I mean, I arrive on scene a lot and they say, oh, patient initial rhythm
Right.
was an asystole.
Right,
And then
reported
all this-
asystole.
Right, and then all of a sudden it's like, and then they converted to a VFib or something and we shocked them out of it back into a sinus rhythm. It's like, okay, so the initial rhythm was asystole.
Right.
Yes. I'm
because
just
the
wondering if the
electrodes
limb
weren't hooked
leads.
up?
Right.
Right.
And I bet that's what
I don't
it
believe
is.
it. Right. I have trouble believing it.
I've heard that multiple times and I'm just thinking in the back of my head every time, I'm like, there's no way that's possible. That's
Right.
just,
Right.
there must
It's
be
not
some error
really
here
no
somewhere.
cardiac movement.
Right.
I've never seen somebody with
Zero
zero
electrical
cardiac
activity.
movement walk out of the hospital alive. I hear all these stories all the time, but I've never seen somebody with
No.
zero cardiac movement.
Yeah.
Right. Maybe it's just being inappropriately or accidentally interchanged with pulselessness, or maybe it's BLS using a word that
Maybe
they
it's a
just aren't
bradycardic rhythm.
familiar,
Maybe it's just
or-
really,
or
really
that,
slow.
really
Right.
slow,
You know?
Or it's like we looked for the 2 seconds and there was a flat line in between the beats.
Mm-hmm.
Yeah, I am failing to find the actual specific number of survival, though. I don't know why.
Because there are authors who've written for years, if you find somebody asystole, just don't do anything. Right?
Right.
Don't open your drug box, don't do anything, it's not worth it. I mean, for us, or most emergency departments, they could just put the ultrasound on the heart and just take a look. And they can see what the end tidal CO2 is. You know, I'm kind of in that camp where if somebody's asystole and they have no cardiac movement, don't resuscitate.
Yeah.
Right, I am too. Especially, but if it's a true flat line and it's not actually a fine VFib that someone's calling asystole.
I feel
But
more comfortable when I look with the ultrasound and I see
Right.
zero cardiac
I think that-
activity. I don't
Me too.
trust the electrical.
Right.
Have you ever had a patient where they were truly asystole by you looking at it, where you put the transducer on the heart and you saw cardiac movement?
Not that I can think of.
I can't remember one case.
I'm usually not looking at the monitor though during pulse checks. I'm looking at my ultrasound, so I don't know.
But you do know if it's asystole,
Yeah.
right?
I mean, I've never.
No.
And if you see a systole on the monitor, you don't even have to look at the ultrasound sometimes, what I think. I mean, because I've never seen it correlate with an actual mechanical.
Right. Sometimes I guess if somebody says asystole and the end tidal CO2 is higher than I would expect, right? If the end tidal CO2 is 30
I mean,
and they're asystole, I go, really? It's, because sometimes, especially in the emergency department, we have the pre-hospital, life pack or pro pack on the patient, and then we have somebody else's. There's two on, you go, which one is actually on the patient? And one thing shows asystole, but then another one shows some rhythm, and you just go, which is real? Then you go, the end tidal CO2 is 30,
right.
but
I mean,
I
you
have
chalk
seen,
it up to good resuscitation. I mean, at the end of the day.
yeah, I mean, I have seen pretty good end titles when somebody was asystole on the monitor, and I just sometimes go, how could this be? Right, but it must be good resuscitation.
Yeah.
Yeah.
Right.
But is that asystole that's easier to convert? I have to believe that asystole might be the ones that are convertible with good end tidal CO2.
With
Although-
the precordial thump, trying to.
Yeah.
It's been described in asystole too, in addition to.
But how do you have good end tidal CO2 with a true asystole?
Yeah.
Right.
But it probably means you should try for a couple of minutes, especially if the patient's younger.
Sure.
Yeah.
What else do you do?
All right. Yeah. So AJ, did you have any pointers or anything to say about that article?
Well, I've been spending quite a good amount of time trying to get baseline characteristics and how they actually did their data analysis, minus just seeing their model. That's basically the only thing I see stated currently. And let's see if I go to the results. Because they're saying right now, each minute for EMS arrival to epinephrine administration was associated with a 4% decrease in odds of survival for adults. What they don't say is if they did any analysis, if that's truly additive, if each minute is truly additive. In their journal, they do not demonstrate any sort of synergism or antagonistic statistics, basically, to state such that each minute is actually doing what they say. And if it's 4%, 8%, 12%, 16%, 20%. So I found that to be very opaque within their study. They didn't clearly define it. And I don't know if the association is really there, because like you have said earlier, the confounding variables might just indicate that by default. And they don't display a crude to odds ratio either, so that might be the same. And yeah, I was just, it seems iffy to me.
It seems intuitive to me. Like this seems like what I would expect anyway, right? And
Yeah.
people that are non-shockable,
Right.
pressors might help them because they probably had an arrest. Like it's just statistically, their arrest was probably from septic shock.
Yeah.
So
But I did notice it odd though that they don't display any table 2 of their odds ratios and the specific models they use after adjustment per variable. I can't even find it on the Google right now. It's not even listed within this article, which I find quite concerning with who wrote it.
and Circulation's a very well respected journal. So just, I mean, one more time, we already said this, but like for, the subgroup analysis examining neurologic outcome showed a similar association with the adjusted odds ratio of 0.94 per minute. So just go, I mean, you did this before, but just because it's the first time, just go over again what 0.94, how you would translate that.
0.94 would be a decreased risk of 6% per minute, although they're not stating if, to say per minute, you need to do an additive interaction, which analysis, which they actually don't state they did in the study, which makes me concerned if it's actually per minute or just by the way they adjusted it.
And then for like the odds of survival, but so for the odds of survival, they wrote 9% lower with an odds ratio of 0.91, which I guess is really saying the same thing twice, right? And then they write the confidence interval was 0.81 to 1.01. So their confidence interval crosses 1.
Yeah, so it's not significant at any level.
So their
So-
odds ratio of survival was not significant.
Yeah, no.
But
It
yet
was
in
not
their conclusion,
significant.
they say it is, right?
Do they? Let me see.
Don't they say the? Oh
yeah,
no,
'cause
I'm
that-
looking at pediatrics. So it's not significant in pediatrics.
Yeah, so the moment it crosses 1, the confidence interval, it's no longer significant for any odds ratio or relative risk or any sort of similar statistic.
So in
the
pediatrics, it's not
report-
significant.
Right.
Yeah,
So why
the
is it-
reporting
And if you combine pediatrics and adult data, it's not significant, because that's
Yeah.
what they did initially. They initially looked at all comers, and then they had to actually do the subgroup analysis to find the thing that was statistically significant.
Yeah.
So is that a post hoc analysis?
And also when I'm looking at their odds for survival, their odds ratio, I guess. Each one of them, their intervals are like 0.95 to 0.98, 0.95 to 0.99. They're all kind of bumped up there right at the top too. So
Yeah, like I said before, because the sample size is so large, it's decreased the variance, the difference between the lower bound and the upper bound, which is why they're approximating their answer as being statistically significant. And let's see, because they said, anytime they say the word associated, it's technically statistically significant. And they only say that for a few of the values. Yeah, so epinephrine association, and then they kind of stop after once it's not associated, which kind of gives the inference to an uninformed reader that it's decreasing your likelihood when it's really not.
How they define pediatrics? 18 or 21?
18.
So, I'm just wondering when the cutoff is. When is somebody old enough in the study that it becomes significant, right? Like, was 18 to 30 still the same as pediatrics, not significant? But I would have thought pediatrics would have been more significant because they probably went to cardiac arrest because of a respiratory issue.
right, in which case epinephrine intuitively may not help them. Right, the airway would help them.
Okay.
And intuitively, the adults are probably, the statistic portion is probably the older adults are probably make up the majority of this adult population rather than the younger adults.
I would also,
I don't
you know,
know if
the
that would
other
be
thing is,
helpful.
I would also want them, I mean, we all know that PEA is a terrible term. I want to know what they meant by PEA, like what was on the monitor. Like do a subgroup analysis of what they saw on the monitor in PEA, because maybe that's where they find the difference. You know, I mean, I can't believe a Brady systolic rhythm they're calling PEA is the same as like idioventricular rhythm.
Right.
So I don't know what to mean. Although I do think this is a little interesting.
I think it's interesting.
You know, I would want though, I would want a control group of the people in VF, right? Like I want to support that theory that you shouldn't give epinephrine to somebody who has a tachydysrhythmia and cardiac arrest, and maybe use it as the control group, because if they had decreased survival, then I would really be confused.
Yeah.
That would have been helpful for them to include, and they have the data, so I don't know if, you know, why they didn't include it or why.
So there really was no real control group.
No.
Yeah. Interesting.
That's always the problem. How do you find a control group for something like that?
Right. All right. Anything else, guys?
I don't have anything else, no.
Okay, so the last thing I'll say before we shut off our Facebook Live is that don't forget May 22nd is our big EMS conference. For everybody, if you sign up through the website, it's May 22nd, 4 p.m. to 10 p.m. I just today got New York continuing education credits approved for 5 hours. So that was a lot of work and effort, so everybody from New York has to come for both ALS and BLS, and will be good for both ALS and BLS CEUs in New Jersey as well. And we want everybody to sign up and then come Robert Treat Hotel Ballroom, May 22nd, 4 p.m. Don't be late because we're doing some really cool stuff at 4 p.m. And if you bring an emergency vehicle, we got free parking for you. Otherwise, parking is across the street. And if anybody is coming from far away, we got hotel rooms at the Robert Treat Hotel that are pretty inexpensive. And we'll have food too. So make sure you sign up via the website, www.emsfellowship.com. Anything else?
I had a great flyer up while you were talking about it, so
Perfect.
everybody can see everything.
We have 20 great speakers too. So, okay, we'll shut down Facebook Live and we will see you next week. Next week we will be in Newark doing Journal Club. And I'll send the articles out by Sunday. Okay, thanks for listening.